Good morning, everyone. We might just make a start. We're about 10 minutes behind, which we have a packed schedule, so we hope that you will have a good conference. First of all, thank you all for attending today on a Sunday for the first Iraqi Health Professionals Association medical meeting. I hope you will enjoy it, and I hope this will be first of many to come. Just to tell you a little bit about the conference and how it started. This is organized really by a handful of people. I mean, what you see is a few people who worked tirelessly to put program together, to get sponsors so you can all enjoy a conference without much cost, and to get excellent speakers who will, I'm sure you will enjoy their talks. They have wealth of experience in their subspecialty. Before we start, I'm sure you all agree that our beloved country, Iraq, is going through difficult times. And we support the peaceful demonstrations and condemn any killing regardless of the cause. Solidarity, we call for solidarity in Iraq and abroad. And may I ask you all to stand a minute's silence in respect to people who lost their lives in Iraq defending their rights. All right, thank you. It's not truly a minute, but close to. So before we start, I'd like to thank people who really put hard efforts together to put this program, and we met many hours, worked, for several months to get this conference happening. First of all, I have to acknowledge the efforts of Dr. Salwa Kakukli, who is a GP, who worked very hard before the launch of this association, supportive of this association, worked very hard to get this conference happening. So thank you. Laith, who's a plastic surgeon or the vice president of the association, Faiq Isa, our IT expert, and who put all the program and all the IT ads and everything. Adnan and George for their support. Adnan is one of our chairperson for the morning session, and George who's running around. And there are other members of the board who we will mention them as we go. We will have to thank the sponsors. Without them, we wouldn't be able to hold this meeting. And I encourage you all to visit their stations outside, have a look at their products. There's a lot to learn from the sponsors as well, and I hope we can all support them just like they support us to have this program. So our association is the Iraqi Health Professionals Association in Australia. It came, this idea came about the beginning of last year when we thought of having all medical and health subspecialties and allied health under one roof. I think we all work collaboratively together. We need to support each other to be able to serve the community in large. So we launched last year, the 2nd of December, and a lot of you were present in that. I was just going to put a couple of slides to tell you what we promised and what we have done so far. So first of all, we're not for profit and not religious and not political organization. We have we cater for every person. So these are slides from last year. You can probably see the logo has changed since then, but that's the slides of the launch. Our objectives were to establish a network among all health professionals, have database, we communicate together, we get socially together. Our plans for 2019, that was December last year, the talks, was to have a medical conference, which we promised to make, and here we are. Social activity, and we had the getting together at the gala dinner, the working toward newsletter and professional directory, which we met as well. And we talked about educational gathering, social gathering, discount for event fees. Well, this is a free, and a database, a newsletter, and I think we fulfilled our promise. So what we've done so far, we built our website, and thanks to initially Laith and then Faiq, the Facebook page. I encourage you all to visit the website and have a look at what the events and the newsletters all saved there. The gala dinner, which we held, and we had 200 people attended. It was a great night. I think you all agreed, people who attended. We had a professional directory which we established, and people are putting their details in the professional directory. We started the mentor program. We were mentoring new arrivals, AMC, new dentists, new pharmacists. Anyone who wants a helping hand, we're here to help. Again, I encourage all senior people to log in as mentors, so we can assign people who come in looking for mentor to the person who can lead them the right way. We have monthly newsletter, which are now been emailed to all members of our organizations, and we're working really together to bring our community all under one roof. There's some photos of the gala dinner for people who attended. Our board members, myself, Sam Suhaili, Laith Barnuti, Faiq Isa, Salwa Kirkukli, I think she's working outside like usual, just to make sure everything is happening in an appropriate way. Adnan Rubai, who's an ophthalmologist, George Damouk at the back, Zina Mardini, Jabbar Kadi, a dentist, and Fadl Khalil, who's a surgeon, and Ryan, who's a medical registrar. So this is the website and the email for any information. And without further ado, I think we'll move on to the first session. I'll hand to the chairperson. Thank you. Thanks for coming again.
Okay, good morning everyone, and my name's Dr. Marwan Obaid. I'm an endocrinologist. I'll be co-chairing this morning's session. Sam and your committee, thank you for inviting me to speak during your conference today. Congratulations to you for putting this program together. I know it's not easy to put a conference together, and I'm glad to see some familiar faces, and I'd like to thank all the Iraqi GPs that I've met over the years. I can see one there in the back that have wonderful people and have been very supportive of my own practice. But anyway, we better get started because it's a tight schedule. So our first speaker is Dr. Pankaj Arora from Royal North Shore Hospital. He's a senior staff specialist who's the founder of the WISE Emergency Clinic, the first walk-in emergency clinic in Sydney. Maybe he can tell us briefly about that. So he's going to talk to us about acute complications and hyperglycemic emergencies. Thank you, Pankaj.
Good morning, everyone. First of all, I must thank thank the organizers of this Iraqi Doctors Association for inviting me and giving me an opportunity to be the first speaker in the first conference. Thanks to Laith, thanks to Sam, and thanks to the whole Iraqi community. Just a few words about, I've been an emergency physician for 25 years. I've worked in about 4 different countries. And I've been told wherever I go, in every country you go, you will find an Indian doctor. I must say, after my observation, you don't find an Iraqi doctor in every country, but if you find them, don't lose them. They rock. And this is from first-hand experience. There are so many doctors in this room which I have worked in last 10, 15 years while I've been in Australia. And I must say, I must congratulate you guys, your hard work and the effort you put in your patients. I'll talk about my talk, but as I've been a passionate emergency physician for a very long time, and of lately, my passion grew into looking at that we are dumping a lot of emergencies in the hospital, where hospitals are getting overwhelmed. And with a group of emergency physicians from North Shore, we came up with this concept of walk-in emergency clinic to see that we can look after the 70% of the patients who actually don't need hospital. Can they be looked after somewhere else? So just a quick brief on that, and then we'll get going on the...
It's an emergency department, but not like you know it. No wait times, no triage system, just immediate specialist care.
It'll be a one-stop shop in terms of their assessment and treatment.
The new Wise Clinic at Macquarie Park is a walk-in centre with 15 senior emergency physicians plus a network of specialists on call. With 70% of patients who present at hospital emergency departments never getting admitted, this clinic caters to those with non-life-threatening conditions who still need urgent care.
Broken bones, kids with fevers or diarrhoea and vomiting, and patients with abdominal pain or chest pain.
Wise is equipped with blood testing, pathology, X-ray, dental X-ray, CT scan and ultrasound to avoid referrals, delays and to fast-track results.
Immediate access to those results when they come up, and that will allow us to therefore make good decisions early on appropriate treatment.
It came in handy last week for John Gill's daughter Ellie, struck down by a severe stomach bug. She was dehydrated from vomiting.
She was really sick. I was really concerned. I didn't want to go to a normal emergency where you have to wait possibly hours. I knew she needed treatment straight away.
When Jatinder presented in excruciating pain with chronic pancreatitis, he received express emergency care.
They did the blood tests. They immediately took me for a CT scan so that they could see what actually happened to the organ at that time.
Regardless of what you need once you're here, whether that be a blood test or a CT scan, you'll pay a single flat rate of $200 on the day, but that isn't covered by Medicare or private health funds.
I'm willing to pay more than that. I mean, you know, it's peace of mind.
Sophie Walsh, 9 News.
Thank you very much for giving patience hearing to that. Look, this is facilities available. Please, there's a booth out there. If you want more information, please feel free to come and talk to me or Alison in there. Now, coming to diabetic emergencies. Now, diabetes is, Greeks have given us a lot in terms of our nomenclature of our medical terminology. So diabetes actually just means is passage of lot of something. And mellitus is actually the sweet honey we talk about. In our emergency career, we have always carried glucose under our pocket, and we always, any course you go to, any training session you go to, you're told A, B, C, do not forget glucose. And that's sort of a thing we say time and again, but still forget. Still don't do the basic glucose, which is just a tiny instrument available in every office, but it's such a rewarding thing to save a life who is going to die in a matter of minutes or times if we pick this up, especially in diabetics as well as non-diabetics as well. So we'll just go through a few areas which we'll cover here, which wanted to cover just a touch on. I'm sure then Dr. Abid, next speaker, would be giving in detail the diabetic pathophysiology, but I'll just touch briefly on that. And then I want to deal with 5 emergencies which we commonly deal: the diabetic ketoacidosis, hyperglycemic hyperosmolar state, hyperglycemic without obvious acidosis, and hypoglycemia, and some other associated emergencies which we'll just package in one slide. What is the role of a primary physician in a diabetic emergency? Prevention, the biggest one, and education to the patients so that we can actually prevent these episodes from happening. Regular monitoring of their diabetic condition, early identifications of their risk, and timely referral to the hospital care if required, and providing urgent care while you're waiting for a transport. I think these sort of fill up the broad way where we want to, the condition itself will be managed in an emergency department, but this is something which I think each of us as a doctor should be aware of what steps to do. And they're not rocket science. I don't want you to take too many messages from this talk. If you just take 2 or 3 big messages, that will be really helpful. Type 1 diabetes, I think this room is full of really smart doctors, and we know it's a condition where we are lacking insulin. And type 2 diabetes where insulin isn't working. And insulin has got 5 major functions which we should keep in mind while managing our acute situations in diabetic emergencies. It drives glucose into the cells. If it doesn't go into the cell for creating energy, it's going to cause hyperglycemia, and those effects are detrimental. And it drives potassium into the cell. That's something to remember. It can create problems if we don't keep that in mind. It's an anabolic and a glycogen storage hormone. It blocks fat breakdown and it blocks protein breakdown. Insulin deficiency leads to hyperglycemia, leads to ketoacidotic production because all the glucose is outside the cells are starving, and they start producing ketones, and hence we'll end up in acidosis. And hyperglycemia itself leads to osmotic diuresis and dehydration. 2 conditions, I'm going to take them together because for the sake of a primary health physician, we manage them pretty much similar in the first few minutes of these emergencies. Diabetic ketoacidosis, mostly hyperglycemic, but euglycemic. I will bring your attention to this, which we have recently started saying some adverse drug reactions have been notified, but I think we are seeing more than in emergency department than they are being reported. I'll talk, I've dedicated 1 slide to that. And hyperosmolar hyperglycemic state, which is a complication of a type 2 insulin, non-insulin dependent diabetes. If you put them together, diabetic ketoacidosis is a condition which is because of lack of insulin. Hyperosmolar is because of not being able to use insulin fully. How do they clinically differ? Majority of the hyperosmolar will have sugars more than 25 millimole, whereas diabetic ketoacidosis by definition should be above 11 to 15. pH is low, 7.3 in diabetic ketoacidosis. pH is always above 7.3 in the hyperosmolar. Bicarb has to be less than 15. In hyperosmolar, it is more than 15. Ketones are elevated in both, but very highly in high numbers in diabetic ketoacidosis because of your cells being starved. And in the hyperosmolar, they can be high, but usually less than 3. A pseudo-hyponatremia exists in the diabetic ketoacidosis. We have a calculation to find the corrected sodium, but not going into those details. And the hypernatremia is actually detrimental, and it is because of the hemoconcentration can be a complication and is got a big mortality to it. So these are the basic differences in these 2 types of diabetic emergencies, both related to hyperglycemia in most of them. And then we look into why these kind of situations happen. Insulin lack is the most common factor in Australia or in Western countries to be the cause of diabetic acidosis. Rest of the things can be common in both of the conditions. And as a part of our workup, we look into, once we have stabilized the patient, to find why this happened. And majority of the type 1 would be either non-compliant, or their pump is not working, or something like that. That's why they present to us in a ketotic phase. This is something which I've seen 8 patients of euglycemic ketoacidosis directly related to SGLT2 inhibitors, which is being used pretty commonly nowadays. It's a good drug. But like apixaban and NOACs came into the market, emergency physicians were the first one to bear the brunts of the bleeding of, though it has this side effect of this has been played down most of the time, but we have seen of lately last year 8 patients presenting to us with type 2 diabetics in ketoacidosis and on SGLT2 inhibitors. It tends to lower the insulin level, blunt the effect of the insulin level while it's actually lowering the sugar levels. The sugar levels are normal, but the insulin effect is blunted, so the ketoacidosis kicks in. Simple approach to all these patients. I would, for a message to a primary physician, it's hydration, hydration, hydration. There have been a few guidelines being put out there saying give a subcut or a bolus dose of insulin before transferring to the hospital. Not a good idea, I will say, because what you'll end up doing is you give an insulin dose prior to sending them to the hospital. If their potassium is normal, by the time you're going to reach hospital, they'll die of hypokalemia rather than diabetic ketoacidosis. So if a message has to be taken, IV line while you're waiting for an ambulance and a normal saline. Don't confuse yourself with too many solutions. Just normal saline, 20 mils per kilo, a bolus dose would save that life. If you have to give insulin, I would say it should be given in an emergency department once the electrolytes have been taken and a first gas has been taken. Investigating the cause and preventing complications we can look after in emergency department. So the principles of treatments are fluids. Fluids, keep it simple and stupid, 20 mils per kilo. Fluid bolus is the simple thing you can do to save that life at them. Insulin, when they reach the hospital, we tend not to give any boluses. We tend to start an infusion at 0.1 milligram per kilogram. And you want to keep the insulin levels in a way so that they can actually transport the glucose into the cell and save ketoacidosis. And acidosis, to prevent acidosis, you have to have insulin in the body, and if the glucose levels drop because you've given insulin, then you are struggling. You have to give dextrose along with the insulin at a separate infusion to keep the effect of ketogenesis away. Potassium is a big thing which even if the potassium is normal, we start the supplementation of potassium, because once the insulin starts going in, the shift of the potassium happens, and that can lead to various arrhythmias and various issues which are difficult to deal with. Other therapies, bicarb is discouraged as much as possible. Antibiotics, monitoring sodium, magnesium, phosphorus, and in hyperosmolar, because they are very viscous, we tend to start some prophylaxis of heparin. Hyperglycemia without obvious acidosis can be there, and this is kind of a precursor of both these conditions. It's a thing which if we pick up early, we can prevent the happening of the two conditions. The biggest one, hypoglycemia, which kills people instantaneously and damages neuro, is something which has been advocated in all our ALS and ACLS courses. Do not ever forget glucose. But how do you manage that? We'll come to this slide in a minute. How do we manage that hypoglycemia? Management is pretty simple in simple words, but you have to consider two things. Is your patient conscious or unconscious? Is your patient diabetic or non-diabetic? Is your patient got an IV excess or doesn't have an IV excess? An ABCD standard approach to their airway, to their breathing, their circulation, and obviously you have taken a glucose, and the glucose is less than 2.6 as per definition, they are hypoglycemic. What do you give? Glucose, grab anything, a lolly, a chocolate, anything which you have around if they are conscious. If they are not conscious, make sure you have a hypoglycemia kit which has glucagon in it, and intramuscular glucagon gives a good response within a couple of minutes to anti the effect of the insulin. And how much glucose to do? If you're able to get a line in, the recommended dose is 50% glucose, 50 mils, which will give you 25 grams of glucose in the system. And if it's a child, in a child the recommended dose is of 10% dextrose, it's 2 mils per kg. It used to be 10, they brought it down to 5, and then to 2 mils per kg. So these are the two sugars you will use intravenously. If you don't have an intravenous access, then glucagon is your friend, or a glucogel is also available, which you can just put under their tongue or rub it on their gums. These are the two things, if you want to keep in your practice, I will not discourage you from doing it, and can save some life. If someone has taken lots of sulfonylureas, then obviously this is a hospital medicine. We will use octreotide to block that effect as well. 5 other common medical emergencies which we see, which are actually red flags and associated with emergencies. Diabetics can have more cardiac events, diabetics can have more stroke events, sepsis, renal tract, vascular, diabetic, and perioperative complications. I think they make the best use of this time and conclude the talk here, and if any questions, please feel free to ask.
I personally worked for many years in emergency, about 16 years in emergency. I was senior person. But during the last few years, I worked for general practice. I've seen the course shifting from the emergency to federal and federal, passing the ball to the state. How can we solve this problem? Because really ready for it.
I think these are politicians.
You need simple, you have the respect to either all of them become federal or all of the state.
I know, this is a problem which we have been looking.
Really, it's a big problem.
Yes, I don't think we have an answer for that.
Yeah. Causing the patient, especially elderly patient, you send them a few times to do ECG somewhere, blood test somewhere, CT scan somewhere, X-ray somewhere, and this is also difficult for elderly.
Absolutely, our health system is very fragmented. I totally agree with you. Can't say. But do we have anything in our hands as physicians? I'm not sure.
Okay, any questions?
What is the most common presentation that comes with the diabetic ketoacidosis, like as a SNAP specialist?
Okay, so that's a very good question. I should have mentioned that the commonest presentation is they are altered level of consciousness.
So they come with like almost
confused, they could be confused, they could look like stroke, they could look like any syndrome. So you have to be just putting this as your differential diagnosis in every condition. That's why I say do not forget glucose in any condition you see. Walking in an emergency department, yeah. Anything else?
Any more questions?
Do you know?
I'll be making some comments about SGLT2 inhibitors and euglycemic DKA in my presentation. So,
awesome.
Yeah, there's one more question. We've got a couple of minutes now, I think.
one last question regarding the glucagon that you mentioned earlier. The kit itself, it doesn't have to have, you don't have to have an IV access, right?
You can give it intramuscular or subcut, either.
It will work within minutes, right?
Correct.
Sorry, because you said that you're going to discuss my question, your session, just because SGLT is one of the common medications. We use it in the GP set for the good control for the poor control diabetes.
I'm going to be explaining to you where they fit in and how beneficial they are, apart from glucose lowering. And but why don't I get started into? I'll get stuck into my presentation, and then I'll take some questions about SGLT2, and because it is a topical question, it's important. I agree with Dr. Arora. I think what was shown in the clinical trials was a very low rate, and it's still very uncommon. The benefits still outweigh the risks, but we are seeing probably more cases in real life because we're using the drugs so frequently, because they're such good drugs and they save lives. They don't just lower glucose. So we'll come back to your question. I won't forget you.
Thank you.
I'm pretty sure we'll keep using this drug, but just to be aware that that's not that uncommon is important.
Yeah, we always tell the patient that you have to drink a lot of fluids when you start this medication, just to avoid this issue. But this is the only thing that we have to tell them, and there is more things we have to warn them. Let us know, so to reduce the rate of.
Thank you. Thank you, Dr. Arora. We need to move on. I call upon Dr. Marwan Obaid. Dr. Marwan is very well known to us. He's a staff specialist endocrinologist at the Diabetic Center, Bankstown Hospital, conjoint lecturer at University in New South Wales, and his private practice at Inner West Specialist Center, Burwood.
Okay, thank you, Adnan. So I've got a lot more slides than I have time to discuss, but my job is to give you a message at the end of the session. So just some hands up, who's a general practitioner in the audience? Okay, great, so there's quite a few of you. So look, type 2 diabetes has come a long way in the last 10, 15 years, but particularly in the last 5 years. There's been a proliferation of treatments to control glucose and also injectable therapies, different insulins, but especially with the tablet therapies where as general practitioners you're dealing with tablet therapies every day. And so there's been such a proliferation of therapies, and trying to understand where they fit in after metformin is challenging, and I can understand that. But what we are excited about in type 2 diabetes is that we don't just have new medications that can control glucose, we have medications that can offer patients more than just glucose lowering, and that is reducing the risk of cardiovascular disease, heart failure and chronic kidney disease. Because people with diabetes, they don't die from their glucose level, they die from cardiovascular disease. So, and I apologise if I rush at some points, but there's been a new guideline regarding the management of type 2 diabetes that was published and presented late last year, and it looks quite confusing when you look at it, and it's there on the right hand side, but I'm going to try and simplify it for you. So type 2 diabetes is a complex disease, but if you try and keep things simple, and the guideline attempts, it looks confusing when you look at the actual guideline, and it's the ADA, the American and European guidelines. They're going to be adapted into the Australian Diabetes Society guidelines, just hasn't happened yet. But I want to try and keep it simple and send you home with a simple message at the end of the day. And some of you are probably already putting into practice this message anyway, based on all the cardiovascular outcome trials in type 2 diabetes, particularly in the last 5 years, that have shown some rather stunning results, surprising at times, but very beneficial for our patients. So on the left here, first-line therapy is still lifestyle and metformin. Metformin has been around for a long time, it's safe, it's cheap, it's well tolerated by most people, and it's weight neutral. So that's our first-line therapy. Lifestyle's important. We've got to always reaffirm, re-explain to patients the importance of being careful with diet and exercising to their limits. But not all of our patients with type 2 diabetes are able to get an HbA1c target of 7% or less on metformin and diet and exercise alone, as you know in general practice. So when the HbA1c is above target, what's next? Now, previous sets of guidelines have focused on the various therapies and their side effect profiles and what may be, and their hypoglycemic risk as to what may be the next best step depending on what the patient can tolerate. But now our guidelines have changed. And they've changed because the first consideration, as you can see here on the slide on the right hand side, after lifestyle and metformin, is the first consideration is for you as a physician to determine whether the patient has atherosclerotic cardiovascular disease. Okay? So atherosclerotic cardiovascular disease could be the history of a coronary artery disease event such as acute myocardial infarction or a stroke or peripheral vascular disease, or even just somebody that has coronary artery stenosis on a CT scan, or unstable angina, or positive exercise stress test, or a history of heart failure. So that's the first thing you need to do. When you have that patient in front of you, and it may not be just the patient who's on metformin and lifestyle, it may be someone you've been managing for years, and if that patient has a history of atherosclerotic cardiovascular disease, you need to stop and rethink what treatment they're taking and consider them for one of the agents with proven cardiovascular disease benefit. So one of the classes of drugs, one of the agents from those classes that we know not only lowers glucose, but separate to the glucose lowering, gives that patient a reduction in cardiovascular disease outcome and chronic kidney disease as well. And so patients with type 2 diabetes in part are very large financial cost in terms of cardiovascular disease. And you can see on this slide the risk of heart disease or stroke is higher, risk of mortality, cardiovascular disease causes 2 in 3 of all deaths for people with type 2 diabetes, and it reduces life expectancy. So people with diabetes don't die from their glucose. Yes, they develop acute hyperglycemic complications, as Dr. Aurora just explained, or hypoglycemic complications, which can, unfortunately, but we don't see very much of these days, cause them to die, but most people with diabetes are dying because of cardiovascular disease. So when we manage someone with type 2 diabetes, yes, it's really important to control their glucose, but it's also important to reduce their risk of cardiovascular disease. And so yes, it's important to choose a drug which reduces that risk, but don't forget also about controlling their blood pressure, lipids, smoking cessation, weight loss, all the other non-glucose cardiovascular disease risk factors. So I'm going to give you a case of a patient, and so Jim, 63, type 2, history of hypertension, coronary artery disease, diagnosed following an exercise stress test. He's on an ACE inhibitor, a nitrate, a statin, and aspirin. He was first diagnosed 5 years ago. Let's say he was diagnosed before we had SGLT2 inhibitors. The SGLT2 inhibitors have been around since about 2014/15, and so he was on metformin. His HbA1c was above 7%, and he's overweight. So what did you add on after metformin? A DPP-4 inhibitor, such as sitagliptin, completely appropriate, pre-2014, before we had SGLT2 inhibitors, because that was probably the next best step, because you're looking to choose something that's going to control his glucose, but not going to cause him to gain weight. So you might have also considered a sulfonylurea, but a sulfonylurea you might have avoided because it causes hypoglycemia and weight gain in some patients. His BMI is 31, eGFR was mildly decreased. He was admitted to hospital sometime down the track, let's say months later, with chest pain determined to be due to acute myocardial infarction. He died after a fatal cardiac event. So this is an unfortunate outcome, but people like Jim are not uncommon in Australia. An analysis from the Baker Heart and Diabetes Institute in Melbourne showed that 7,000 Australians with type 2 diabetes and cardiovascular disease die every year. So this is an unfortunate outcome, and so what we might be able to do now, based on the evidence that we have from cardiovascular outcome trials, and they were done to check safety. So a lot of the trials that have shown us the very stunning, sometimes surprising results were actually performed because there were some risk signals with some drugs. If we go back 15 years to, say, 2003, do you remember rosiglitazone and Avandia? And there was another drug as well, which didn't make it to market, which looked amazing in terms of their glucose lowering, but risk signals emerged. And so as a result of that, in 2008, the FDA in the US mandated that all clinical trials with type 2 diabetes drugs needed to have long safety trials to look at their safety in terms of cardiovascular disease. So I've just told you that we need to reduce the risk of cardiovascular disease in patients with type 2 diabetes, because that's what they're dying from. So we need to also be careful we have drugs that are safe in the first instance, but because those trials were done for safety and they were long trials, what they showed was a benefit. And the EMPA-REG trial with empagliflozin was the first one, and that was in 2015. Excuse me. The EMPA-REG outcome trial established cardiovascular. So the patients in the EMPA-REG trial had established cardiovascular disease. Excuse me. These patients in this trial, it was quite a large trial, 7,000 patients. They all had a history of either coronary artery disease, peripheral vascular disease, prior myocardial infarction, or stroke. About three quarters of them had coronary artery disease, and important to note that about 1/3 of them didn't have a heart attack or stroke before. They just had abnormalities on coronary CT or positive stress tests and, say, a single artery that was stenosed. So was adding a DPP-4 inhibitor the best option for type 2 diabetes in Jim's case? Well, at the time it probably was, but it isn't now. So if you see someone like Jim who's got type 2 diabetes and has a history of coronary artery disease, and his HbA1c is above 7% and he's on metformin only, the next best step is not a DPP-4 inhibitor. The next best step is an SGLT2 inhibitor or a GLP-1 receptor agonist, but in most cases our patients are going to be interested in exhausting tablet therapies. So what about DPP-4 inhibitors? Are they safe? Well, they're safe. You can see on the left-hand side that 4 large trials involving DPP-4 inhibitors that you've all used, so saxagliptin, alogliptin, and particularly the bottom two, sitagliptin and linagliptin. These are all DPP-4 inhibitors as GPs you've prescribed, and we still prescribe. I still use them, but they're not second-line therapy after metformin in most patients. Not everyone, but most patients, especially patients with a cardiovascular disease history or have multiple risk factors that are at risk, and that puts that patient at risk of a cardiovascular disease event. So they're safe in terms of that they don't increase cardiovascular disease on the left-hand side. On the right-hand side, if you look at the top right, the two trials at the top, there was a signal without statistical significance of a risk of increased hospitalisation due to heart failure with saxagliptin and alogliptin, but sitagliptin and linagliptin were safe in terms of heart failure. So they're completely safe drugs and they're quite benign drugs. These drugs don't cause a lot of adverse effects. Most of you have experienced using DPOR inhibitors for probably 10 years now. They've been around since 2008 or 9, and you probably use them with a lot of success in controlling glucose, and patients usually tolerate them pretty well. So, what about the EMPA-REG trial? I've just told you that empagliflozin is an SGLT2 inhibitor. I'm not going to go into the mechanism of how it works, we haven't got enough time, but in the EMPA-REG trial, there was quite an impressive and stunning result in terms of the reduction in this slide, cardiovascular death. There was also a reduction in hospitalisation to heart failure, and there was also a reduction in all-cause mortality. So empagliflozin in the EMPA-REG trial versus placebo in patients with HbA1cs above 7%, in patients who had very good treatment. They were 80% of them were on ACE inhibitors, statins, aspirin, and they were well treated in terms of their glucose, except their HbA1c was above target still, and the HbA1c came down in the trial, but more than the HbA1c lowering effect, what was impressive was the early and sustained response with respect to reduction in cardiovascular death. So this was quite an impressive result, and this was the first of a number of trials in the SGLT2 inhibitor class, and also GLP-1 receptor agonists, which we won't go into, which changed guidelines. And so essentially now, after metformin, if your patient has a history of cardiovascular disease or heart failure or chronic kidney disease or has multiple risk factors and there's a concern they're going to develop cardiovascular disease, the next best step after metformin is an SGLT2 inhibitor or GLP-1 receptor agonist, and in particular empagliflozin, because it has proven cardiovascular disease benefit. So let's look at the number of patients needed to treat to save one life before statins. So this is the 4S trial looking at simvastatin. 30 patients needed to treat one life. This is looking at ACE inhibitors, 56 patients over 5 years to save one life with ramipril, and look down the bottom there, less than 30% of the patients were on a statin, whereas in the EMPA-REG trial, where there's a large proportion of patients that are well treated with drugs that lower cardiovascular disease risk, on top of that, 39 patients needed to treat in 3 years to save one life, and this is type 2 diabetes patients with established cardiovascular disease. So very impressive result. So what about other SGLT2 inhibitors? So dapagliflozin was studied in the DECLARE trial, and on top left, first of all, is empagliflozin. You can see there's a reduction in cardiovascular disease, which I've just told you about. The same wasn't showed for dapagliflozin in the DECLARE study with respect to cardiovascular disease, but it did reduce the risk of heart failure. There is a thought that the patients in the DECLARE trial, dapagliflozin trial, they didn't have the same cardiovascular risk as the patients in the EMPA-REG trial. But certainly there appears to be a very profound reduction in cardiovascular disease death and events with empagliflozin. Heart failure and chronic kidney disease prevention is probably more of a class effect. So I've just said to you that the first consideration is whether the patient has cardiovascular disease. Well, if the patient doesn't have a history of cardiovascular disease, step 3 should be considering whether the patient has a history of heart failure or chronic kidney disease. Okay, so chronic kidney disease, microalbuminuria that's persistent, and or an EGFR of less than 60, chronic kidney disease. If your patient has chronic kidney disease and type 2 diabetes, and your patient doesn't have a history of atherosclerotic cardiovascular disease, or your patient has a history of heart failure, that's the next thing you need to determine, because they are compelling indications to add an SGLT2 inhibitor next line, whether it's after metformin or if the patient's already on metformin and a DPP-4 inhibitor, or metformin and a sulfonylurea. That's a compelling indication, because we now, in 2019, have very good evidence to show that adding these drugs with proven cardiovascular disease benefit not only lower glucose, that extra 0.5 to 1% or more, and help the patients lose weight, but they reduce their risk of heart failure and also chronic kidney disease progression. And these are problems that are common in patients with type 2 diabetes, as is shown on the right-hand side of this slide. People with type 2 diabetes do have a higher incidence of developing heart failure. Interesting point is that in the patients in the EMPA-REG trial, only 10% had heart failure at baseline, and the patients there was still a reduction in hospitalisation due to heart failure. So not everybody declares themselves with heart failure with type 2 diabetes. It is a problem that is probably identified, underappreciated, but patients with type 2 diabetes do develop heart failure and do end up in hospital with heart failure. So we can give them a drug that reduces that risk, and it's certainly a class effect. The DECLARE trial showed also in patients with and without cardiovascular disease there was a reduction in hospitalisation due to heart failure over the course of the 4 or 5 years of that study. Okay, so that's the slide from the EMPA-REG trial showing the event rates decreasing with empagliflozin in the blue, the light blue versus the dark blue, and again it was an early response that was sustained over the course of the trial. And the earliness of the response, you see the curves separate early, suggests that it's not due to atherosclerosis, that it's due to a hemodynamic effect. It's due to another effect, not due to atherosclerosis, the classic way in which you prevent cardiovascular disease when you give someone an ACE inhibitor or a statin. 4 minutes left. If the HbA1c is above target, as I've just mentioned to you, and the patient had atherosclerotic cardiovascular disease or heart failure or history of chronic kidney disease, these are compelling indications to add an SGLT2 inhibitor. And in terms of renal function, this is often a question I get. There's some concern about the effect on renal function of using an SGLT2 inhibitor, and the effect of an SGLT2 inhibitor on renal function is that in the first few months there is a decline in the eGFR, but that's because of the way the drug works at the level of the nephron, which I won't be able to go into detail. But it usually, as you can see, it drops, but then it picks up. But over the course of years, there's actually a protection benefit. And it's been clearly shown now in a number of trials that the drug doesn't cause a worsening in renal function. On the opposite, it actually shows a protection of kidney function over time. That's been clearly shown across all the drugs in the class. So this is a summary slide of the HbA1c lowering effect, weight loss effect, blood pressure lowering as well is something that we see with SGLT2 inhibitors. You've all seen that. Prevention of death and hospitalisation due to heart failure. Now, what I want to talk about before I get... Okay, so we'll finish up on this point, and
you have 2 minutes.
2 minutes, yep, I've got my own timer here as well. So urinary tract infection, there was no increase in the overall rate of UTI, complicated UTI or pyelonephritis with Jardiance empagliflozin versus placebo. But if somebody has a history of recurrent UTIs or a history of urosepsis, I think you'd need to be cautious about using this drug. Now finally, not on this slide, this is increasing rate of genital tract infections. This is something that it happens, 3 to 4% of patients, but is usually simply treated. Now, in terms of SGLT2 inhibition and diabetic ketoacidosis, I've already mentioned in commentary to the previous presentation that it is something that we need to be wary of. Quite simply, I tell my patients this. I say, if you become unwell, if you develop a fever, if you develop an illness that causes nausea or vomiting or gastrointestinal losses, stop taking your drug and restart it once you've seen your doctor and you're better. You're back to eating again and you're feeling like your normal self. Okay? You shouldn't go on to the starvation diets. Be very careful about following the the diets I'm referring to, the diets where there's a prolonged period of starvation or fasting if they're on an SGLT2 inhibitor. And they should maintain carbohydrate intake. Doesn't mean they need to maintain high carbohydrate intake. You need to maintain a balanced diet where you're having carbs with your meals, but you're not having excessive carbs that cause hyperglycemia, but you're not omitting carbohydrates altogether. And patients who are on insulin, who we give SGLT2 inhibitors to, be very careful about winding back their insulin dose. If they're going to reduce their insulin dose because the SGLT2 inhibitor is working and lowering glucose, reduce the insulin dose slowly under the supervision of a GP. If you take the appropriate measures in advising and educating your patients who take an SGLT2 inhibitor, you will avoid most cases of euglycemic DKA. The cases that I've seen at Bankstown, where I also work, and I've seen probably about 4 or 5 patients now in the last year or two, they all were unwell. They were patients that were unwell in terms of they developed an intercurrent illness. they all had some intercurrent illness that caused them to tip over, or they were starving, or they were following. There was one particular patient that dropped his insulin and had following a starvation diet. And one final point before I finish up is that in your patients who are about to have a procedure, stop it for 3 days. I think most of you have received that message, but they need to stop their SGLT2 inhibitor for 72 hours beforehand based on the half-life of the drug. So I think I'll finish up there, and we'll take any questions. We got any time for questions, Adnan?
I think we don't have time for a question. Thank you, Dr. Obaid. Thank you very much for this interesting presentation. I call upon Dr. Sam Suhaili. Dr. Sam is a consultant gastroenterologist at Campbelltown Hospital and researcher at Garen Institute, and he's a lecturer at University New South Wales and University Western Sydney. Dr. Sam will talk to us about facts about fatty liver disease in diabetic.
Thank you. I'll try and make it brief just to catch up with time. Hopefully I don't go the 15 or 20 minutes as well. It's just a brief message about fatty liver disease and diabetes, which is a problem that a lot of people in the audience probably face. It's not only gastroenterologists and hepatologists, but endocrinologists, GPs, dietitian, physiotherapists, people who deal with metabolic syndrome will come across fatty liver as well. So stages of fatty liver disease. From a healthy liver, we get into hepatic steatosis, which is just a simple fat in the liver, into steatohepatitis, which is fatty liver plus inflammation, and then into fibrosis. And, oh, that doesn't come up, sorry. There we go. So it goes into stages from hepatic steatosis into steatohepatitis. Both are reversible, and then finally we get into fibrosis, and advanced fibrosis means liver cirrhosis, which gets into the irreversible stage. So what about NAFLD, or non-alcoholic fatty liver disease, and diabetes? Up to 70% of people with diabetes will have fatty liver disease, and that's much higher than the general population. Biopsy-proven non-alcoholic steatohepatitis, or NASH, is present in about 20%, and advanced fibrosis in 5 to 7% of diabetics. The risk of developing diabetes also increases in patients with non-alcoholic fatty liver disease by about 5-fold. And we now know that type 2 diabetes actually worsens the histology of fatty liver. So we get more advanced phase of fatty liver disease, whether it's non-alcoholic steatohepatitis or advanced fibrosis and cirrhosis in people with diabetics. They're more susceptible to develop NASH and also at higher risk or higher rate of developing hepatocellular carcinoma. So how do we define fatty liver? It's basically simply the presence of hepatic steatosis when there is no significant alcohol consumption and no other cause of elevated liver enzymes or fatty liver, for example, Wilson disease, alcohol, and other causes. We rely on simple algorithm. We check liver function tests regularly for our diabetic patients. I think it's just part of the regular routine checks. But be wary that fatty liver can be present in the, with normal ALT and normal liver enzymes. It doesn't rule it out. And even sometimes steatohepatitis or fibrosis. Imaging with ultrasound, we always sometimes see reports of increased hepatic echogenicity on ultrasound, which usually refers to fatty liver. On CT, it appears hypo-attenuating. MR elastography is now being used as well. Liver biopsy remains the gold standard, but we rarely refer to liver biopsy for a simple fatty liver. It's just basically diagnosis based on imaging and exclusion of other causes. In a patient with diabetes and fatty liver, try to assess the presence of fibrosis, because that's really the important. If there is simple steatosis, your patient will not die from complication of liver disease. They will die from cardiovascular disease. But if there is advanced fibrosis, that's when your patient could progress into cirrhosis. Especially diabetics are at higher risk of getting into cirrhosis and hepatocellular carcinoma. So sometimes your patient might have normal LFT, and then you could see them having liver mass lesion and HCC secondary to fatty liver and steatohepatitis. So be wary, assess the degree of fibrosis. So there are few scores. We use, the most widely used, we use NAFLD fibrosis score calculator, and these calculators are present online. You can easily just put NAFLD fibrosis score calculator. Most of the calculators rely on age, the presence of diabetes, ALT, platelet, and albumin. That's the general way to look at patients and assess whether they have advanced fibrosis or not. There is the FIB-4 score, which a lot of hepatologists like as well and use. And then we have non-invasive imaging means like the fibroscan, the elastography, the transient elastography. The problem is in patients with high BMI, obese, it might not be accurate. So you have a fibroscan reading of 4, which means it's normal or minimal fibrosis when they actually have nodular liver when you do ultrasound or CT. So don't always rely on them, but they are a good additional ways of assessing the degree of fibrosis and advanced fibrosis. So that's the NAFLD fibrosis score, and you can have an online calculator. And as I said, mainly age, BMI, diabetes, and platelet, ALT, AST. So I don't necessarily agree with all what's on the slides. That's from actually an endocrine journal talking about patients with a pre-diabetes or diabetes. ALT and ultrasound normal, I think that's fine. You can just periodically reassess. If they are abnormal, then you need to assess for the presence of fibrosis. But also in people who have long-standing diabetes, high BMI or morbid obesity, and patients who always have high HbA1c. Even with a normal ultrasound and ALT, be wary of the presence of fibrosis. Liver biopsy is rarely used. We use other means and then maybe refer if in doubt. The aim of treatment is to reduce disease activity and delay progression of fibrosis. But as I said, majority of people with fatty liver disease actually die from cardiovascular risk. So make sure you try and modify their cardiovascular risk, and high triglyceride is a good indicator. We say lifestyle intervention and modification. I'm sure a lot of people who deal with diabetic patients, you try and relay this message to your patients. It's sometimes hard to achieve good weight loss, hard to maintain, and adhering to a lifestyle intervention for a long time is something difficult. But we now know for a fact that if you lose 7% of your diabetic patient, obese patient, lose more than 7% of the total body weight, that improves the steatosis and necroinflammation, the steatohepatitis. If they lose 10%, they get regression of fibrosis. And that's, so the weight loss is the key message, and therefore obese patients with diabetic, well, they might benefit from bariatric surgery. We now know that for a fact that it reduced steatosis, the degree of steatosis, biopsy proven by in about 90% of people, and actually regressed fibrosis in about 50% of people. That's from sleeve studies. There are weight loss medications. The orlistat, liraglutide can also be considered. Pioglitazone, I know it's not on so much in practice these days, and there are some potential side effects, but it's the proven medication that improve steatosis, inflammation, and fibrosis. There are potential adverse effects, including some studies suggest increasing risk of congestive cardiac failure, bladder cancer in men, and the most important problem is weight gain. So that's something that you try to avoid in people with NAFLD. It helps steatosis, but it makes people put on weight, and for obese patients it's a problem. Vitamin E has been proven to reduce progression of fibrosis and steatosis, but it's in high dose. So the most studied dose is 800 unit, which is not available. So I tell my patients to take 1 tablet of 500 one day, 2 tablets the next day to try and even it. But there are, again, some potential side effects. Vitamin E is a good antioxidant, helps with fatty liver disease, proven in people with fatty liver disease. However, there were some studies suggest that there is an increase in all-cause mortality. That has been a bit of controversial area because some studies showed increased all-cause mortality, others didn't, and meta-analysis said it's neutral. So we don't use it in all people. We try to be careful about using vitamin E. It also potentially can increase the risk of prostate cancer in men. So men, family history of prostate cancer, I don't use it. Women, maybe, mainly if they have steatohepatitis, we think they are at risk of progression of fibrosis, well, we're going to use something and it's safe to use. Liraglutide has a proven efficacy as well. I think I'll skip this busy slide just in the interest of time. But again, the most important message for you is control cardiovascular risk. Not only think about fatty liver in people with fatty liver. So think about fatty liver when you see a diabetic patient. You need to know that diabetics are at more risk of severe form of NAFLD, and that's including steatohepatitis, liver cirrhosis, and progression into hepatocellular carcinoma. They are at higher risk of HCC. We see actually a lot of patients with HCC, unfortunately, in diabetics. And first diagnosis, liver cirrhosis, liver mass, proven hepatocellular carcinoma. So be wary of that. Non-invasive methods are available. And you can use the NAFLD fibrosis score. You can use FibroScan and transient elastography. Liver biopsy rarely needed. Remember, if you advise your patient to lose 10% of total body weight, that results in regression of fibrosis. Lifestyle modification remain the mainstay, but it is challenging to maintain. And you have some options of pioglitazone, which, it's on the fence. Vitamin E in appropriate patients is good choice, especially people with NASH or people you worry about progression of fibrosis. And, bariatric surgery, remember, results in regression of fibrosis. So even people who have proven cirrhosis, sometimes they do regress, which is thought to be irreversible, but people who lose good amount of weight through bariatric surgery often could regress. I think I'll stop here and
Thank you very much.
I try and keep it short and simple.
Sam, I might ask the first question.
Yeah.
Patients with type 2 diabetes who are overweight have abnormal liver function tests, very common.
Absolutely.
Which of those patients, and I'm sure the GPs have the same thoughts in their mind, which of those patients need further imaging and also need assessment for fibrosis? So how do we decide? Because it's so common.
Yeah, look, a lot of diabetics do often have high GGT, and that's indicative of a degree of fatty liver. We often look at ALT more than GGT. And if the ALT is elevated, ferritin is elevated, that might indicate a degree of steatohepatitis. And sometimes we see low albumin, low platelet, that's probably more advanced degree of steatohepatitis. But the one with high ALT, especially if it gets in the hundreds, I will worry about them, and they might have an advanced degree of steatohepatitis. Yeah. All right. Thank you. Thanks.
Okay, so next speaker. Let's get the microphone working. Our next speaker is Dr. Saif Hayek, who's a dentist. And Dr. Hayek's going to talk to us about diabetes from a dentist perspective, manifestations, contemporary treatments and complications. So Dr. Saif is a dentist who is a principal of 4 private practices, founder of the Advanced Dental Implant Institute, and is a clinical tutor at Sydney University. and look forward to hearing his presentation, because I've certainly seen a number of patients over the years where their glycemic control has been difficult to treat until we've sorted out their dental issues, in particularly periodontitis. So look forward to hearing you talk, Saif. Thanks.
Thank you. Well, good morning, esteemed colleagues. Thank you very much for coming here. It's absolute pleasure and an honor to be presenting in front of a bunch of very talented and amazing health professionals like yourselves. I mainly today will be discussing the dental implications and the concerns for us as dentists when we see diabetic patients, and the latest or the modern dental procedures and technologies in treating those patients after controlling their conditions. So I'll skip through very quickly in the interest of time the etiology and the presentation and the symptoms and management, the medical management of diabetes, because I believe the previous presenters already done a wonderful job discussing that, and I'm sure you're all no strangers to diabetes and the management of that. So as you know, diabetes mellitus, type 1 and type 2, we have already spoke about the clinical, the genetics, the pathogenesis, and the islet cells. Other etiologies and drugs, drug or chemical usage and infections and endocrinopathies. As you know, the classical symptoms are the polyuria, the polydipsia, the polyphagia, weight loss, delayed wound healing, and weakness. Diabetes affects the entire body, all the organs, central nervous system, the eyes, the smell of acetone in the breath, the systemic and the weight loss, the respiratory, gastric and urinary, and the liver. It affects all those organs and all the major organs, but there's very little attention given to the oral complications, and there is a very strong relationship between a person's oral health and their general health. In people with diabetes, first signs and symptoms usually of medical conditions are developing in the mouth. The oral manifestations include xerostomia, which is drying of the mouth, burning sensation, overgrowth of the gum tissue and the periodontitis, tooth decay, periodontal disease, fungal infections, the fruity breath that our patients usually complain about, or the acetone breath, and the increased thickness of saliva and the altered taste sensation. This is the typical presentation of xerostomia, and we deal with this on a daily basis in the dental practice. See diabetic patients literally every single day, and we need to be able to manage those symptoms and control and liaise with other medical practitioners to control their condition. And that's the overgrowth of gum tissue, the teeth decay that we deal with, the oral fungal infections, and then the periodontitis or the periodontal disease, and that eventually leads to a recession, loosening of teeth, and then loss of teeth. To manage those, we always assess the glycemic control. We liaise with other practitioners or refer to the physician. We use a glucometer to check there and avert emergencies. And we always schedule patients for a shorter period or shorter treatments and early morning usually. The objective is to maintain the blood glucose level as close as normal as possible. And for us, in dentistry, the dental considerations are to minimize the risk of intraoperative emergencies by taking appropriate medical history. As I said, giving them morning visits, shorter visits, doesn't coincide with peak physical activity. Make sure that the patient has, if they're on insulin, they've taken they had their breakfast and they've had something to eat. And a lot of times we give prophylactic antibiotics to if there's an established infection or as a pre-operation contamination or major surgery. One of the most serious consideration for us in the dental practice is the hypoglycemic emergency or the insulin shock, and basically, as you know, it's a life-threatening condition or situation, and it occurs when the blood glucose drops. The features are confusion, sweating, tremors, agitation, anxiety, dizziness, tingling or numbness, and tachycardia. And sometimes it leads to seizures and loss of consciousness or convulsion and coma. The appointments should be of short duration, source of glucose such as orange juice or lolly or anything like that to be available, prophylactic antibiotics to patients taking high doses of insulin to prevent postoperative infections, and also to always check the blood sugar levels that they are within normal, and make sure that we minimizing any emotional stress, and that's by achieving appropriate anesthesia and have a very relaxing atmosphere. I know it's a bit hard when you come to the dentist. As soon as the signs and symptoms are presented, we should check, when that we're talking about the hypoglycemia, we should check for blood glucose, establish adequate airway, breathing, circulation, and have a carbohydrate of some sort, a fruity juice or or sugar or lolly. If they are unconscious, as the previous presenters have discussed, we can give intramuscularly or even intravenously to try to stabilize and normalize the situation. Diabetic patients should be motivated to maintain good oral hygiene, brushing twice a day, flossing, keep their dentures clean, because that's where usually we get the fungal infections. It's that combination of the dentures and the diabetes. Regular examination, prophylactic measures such as topical fluoride to prevent decay. They should be informed that diabetic patients are more likely to catch dental disease than other patients, and they need to be aware and educated about the preventative measures that we should implement. Cavities should be treated as quickly as possible. Mouth dryness should be treated with salivary substitutes, or ask them to suck on sugar-free lollies or chewing gums. Good oral hygiene, good oral health, maintain glycemic control. Contact the dentist if they notice bad taste or white patches or swollen or tender gums, and encouraging to stop the smoking, as it's very detrimental as well. Once we have their diabetic condition under control, and for a period of time where we are satisfied that they are that their blood glucose level is controlled, it's not having or minimal side effects that it's having on their health and their oral condition, then we can progress to more definitive, more permanent treatments and dental treatments. And they're basically from implants to restore missing teeth, to fillings and crowns and bridges, and in more recent times now we can treat gum recession, which happens after the treatment or the control of periodontitis, when people have their gums receded, which was very irreversible and untreatable. And nowadays, with latest techniques and technologies, we can even treat that, and of course the regular hygiene visits. So if I want to introduce here, we've got Madeline. She is 59. And that's basically a technique we call all-on-4, basically placing 4 implants to restore edentulous patients, or patients without teeth. I was lucky and honored to have more training by Dr. Paulo Malo in Portugal 11 years ago, and that was a shift in the way we treat for dental implants. We used to, for edentulous patients, we used to do bigger surgeries, sinus lift, bone grafting, and that's for diabetic patients. It can add to the morbidity and the possible complications. Nowadays we're trying to limit that, and we use guided surgeries and CBCT, which is the dental CT scans basically. So in her case, you can see that's the before and the after. Aesthetically, facially, also in terms of the self-confidence for those patients, and of course the health of and the ability to eat better diet and look after themselves. It definitely improves when they have good oral health and teeth to eat on. And that's basically the all-on-4. In her case, she's type 2 diabetic as well, but after 12 months of monitoring and maintaining that she has good control for her diabetes, we were able to give her teeth back and restore her smile. And also restore the vertical height of her jaws and the way she looks, and obviously you can see that she looks much younger.
5 minutes.
Yeah. This lady, Kim, you can see that she had multiple missing teeth, the typical dry mouth, and that leads to decay. And again, with the help of the CBCT, in her case, she had softer bone or more porous bone, and therefore we placed 6 implants, or what we call the all-on-6 upper and lower. And that obviously you can see it restores their oral health and their appearance and their confidence. The gentleman, that's the all-on-6 prosthesis. Once we removed all the dentally compromised and periodentally compromised teeth, we established control of his diabetes, and then we were able to do guided surgery to place the 6 implants and have all his teeth restored. And the good thing is, dry mouth doesn't really affect implants or prostheses as it affects teeth, because they're not going to have decay, but it's important that we keep the hygiene, keep the cleaning and the cleansability of the prosthesis, so we have long-term effect. That's basically his before and after for his upper teeth. The new techniques in terms of surgeries or gum surgeries, we used to take gum graft from the palate and then tunnel it or suture it to the teeth to treat the recession. Nowadays, with pinhole techniques, we can restore and treat the recession with literally small holes, or what we call pinholes. And I had the pleasure to be trained by Professor Chow in California, and that's a very that's a video we can show later on. It's just for the interest of time, probably I'll skip that. With the pinhole gum recession regeneration technique, now we make a little hole, as you can see there, and through that little pinhole we can access the gum. We loosen the gum. We then insert collagen in there, and that will maintain the structure of the gum. And you can see the effects when in treating the recession, and the predictability and the reduced morbidity and reduced complications, especially for diabetic patients. Another case where you can see the recession there, and we were able to treat that with the pinhole, very painless and with minimal or less invasive surgery. Again, this patient, she has recession on both sides. I've decided we're going to do one side first to see the effect of that, and you can see the effect of the pinhole gum surgery on the left side in front of you. You can see that's a week on the day of the surgery, a week later, and then a month later. And you can see then we've done her right side, but I think it's interesting to see the effect on both sides. Thank you. Then we've got the full mouth rehabilitation. Once we control the diabetes and have optimum periodontal health, and make sure that we have good control of their periodontal disease, then we can progress into doing diagnostic models and diagnostic wax-ups, and then we can then restore their teeth, transform them into a better bite, better occlusion, better health of their gum. You can see before the control of his diabetes, the gum disease in there and the wear on his teeth. And that's basically after the full mouth rehabilitation, where we restored the teeth, more aesthetic look, and a better control of his gum condition. And finally, Julie, also diabetic, after we controlled her diabetes and maintained appropriate periodontal health. And that's basically her before and after, and you can see the teeth that were badly damaged and heavily filled after her full mouth rehabilitation, and the occlusal analysis and achieving the results that she desired. Well, thank you very much, everyone, and don't forget to floss.
Thank you very much, Dr. Saif. Thank you. We actually run out of time for questions, sorry. It is a tight schedule. So our next, thanks again. Thanks again. I'm sure he's happy to answer any questions at the morning tea break. So we're going to move into the final session this morning. Jacob Abella is going to talk to us about the role of exercise and physiotherapy in the management of diabetes and metabolic syndrome. So Jacob's an accredited exercise physiologist and founder of the Kinetics Health Group. He has a keen interest in the management of diabetes and metabolic syndrome. And as I mentioned earlier, it's not just about using treatments to control glucose and weight, but there's also definitely a role for exercise and diet. So we'll be interested to hear what Jacob's got to say about exercise. Thanks.
Thanks, guys. I'll just get it set up real quick. So thanks for the introduction, and it's a pleasure to be here today. So I do appreciate the invitation to present. And like you guys said, I'm going to be presenting on the role of exercise physiology and how we are incorporated in the management of diabetes and metabolic syndrome. I know we're running a little bit behind, so probably won't go through everything in too much depth, but that's just a quick breakdown of what we're going to do. But I'll skip that and get straight into it. Basically, all exercise physiologists are university qualified, so we do actually have to do a 4-year minimum degree, and we provide a more active approach to the treatment process. So we're less hands-on, like you say, comparatively to physiotherapy. We're less hands-on, we're more active-based, either in the gym or lifestyle modification through exercise programs designed specifically to the needs and the considerations for each patient. Through understanding the pathology and the exercise-related contraindications to diabetes and metabolic syndrome, we were able to elicit certain changes that are favoured upon in diabetes, and in that particular case, we're looking at blood sugar reduction, medication dosage lowering, and potentially removal if we have really good clients who listen to what we say. Weight loss, muscle building, and resensitization to insulin are our main goals in that. So I thought I'd quickly run through the preventative measures with exercise. Basically, I think it's like 61% of adults with type 2 diabetes are not currently engaging in any form of exercise, and being that that's a precursor to, I should say, physical inactivity is a precursor to development and onset of type 2 diabetes. I think it's really good to point out those statistics. But basically, enhancing your blood glucose control through acute glucose disposal, muscle-mediated increases in glucose and glycogen usage, maintaining insulin sensitivity, and lowering the risk of all the associated comorbidities is how exercise would help in the prevention of type 2 diabetes. And the regular or the current recommendation for 30 minutes a day or 2.5 hours per week of exercise is still the current recommendation for non-diagnosed patients. So jumping into the acute training effects, and in particular here, aerobic training. a single session of aerobic exercise will increase insulin activity as well as glucose tolerance for 24 to 48 hours post-exercise. So that's a heightened response that I think is really important in the day-to-day management of diabetes. It also decreases the blood glucose levels, and different studies show different responses, but it can be up to 10 millimoles per litre reduction. I think in that one was a 16-week course of exercise. Those reductions were seen early on, but then maintained throughout the 16-week program. And decreases in plasma insulin levels as well. There's not really too high of a risk of exercise-induced hypoglycemia unless they're on insulin or insulin secretagogues, in which case we would speak to them prior to commencing exercise and educate them on how and when to take some carbohydrates or some glucose prior to coming in. Resistance training has similar effects. Basically, the fasting blood glucose levels will be lower for 24 hours post-exercise. So due to an increase in muscle metabolism of the glucose, along with increased metabolic rates and things like that, what you see is a decrease in the fasting blood glucose for the next day and sometimes the following day as well. Amongst all the research that we base our programs on, they all state that a combined approach is more effective for blood glucose management than either aerobic or resistance training alone. Okay, chronic effects. So these numbers here, the 46.3, 7.1, 12 to 15%, they're specific to certain research articles. Obviously it may vary in that, but insulin sensitivity is probably the biggest one. Reduction in fasting blood glucose levels, reduction in HbA1c, these are all common effects of chronic exercise programming in patients with type 2 diabetes, and are obviously quite favourable in
That's
that.
1.2%, isn't it, to 1.5? That's what it should read. Sorry to interrupt. Yeah.
Yeah? Okay. Yeah, okay. That's fine. Where are we? Oh yeah, so, sorry? No, you're right. No, it's just that was just off a research article. Yeah, 10 to 11% fat reduction was in one article as well. But basically, we're just looking at reducing weight, which will help with other things spoken before about fatty liver and things like that. Just to be able to get away from those comorbidities and other complications. Medication I spoke about before is one of the big things that we look to try and reduce where we can. Obviously we don't make those recommendations, but as a patient is taking their medication and engaging in exercise as well, basically their sugars will start to drop, and then we would obviously instruct them to go back to see their GP and review the way they're managing that to maybe be able to lower the dosages periodically until we get to a stage where the GP is happy to maybe look at lifestyle treatment. And HbA1c as well. So basically, we want to be able to keep it below 7%, just to be able to avoid the complications moving forward from there. So in terms of the recommendations, this is based specifically on type 2 diabetes. And 3 days a week for aerobic exercise is what is recommended, with no more than 2 consecutive rest days. The reason that is we want to be able to capitalise on the acute effects for the exercise, and they typically last 24 to 48 hours. So we want to be able to do an exercise session on a Monday, have the prolonged effect on the Tuesday, and then jump into some more exercise on a Wednesday to be able to have that acute effect roll on. Working at an intensity of 5 to 7 out of 10 is what we usually try to get our patients to be mindful of. We don't obviously want to push them too hard, but we want to be able to have them working within a range that's eliciting the changes that we want without having to create any other complications. 50 minutes is plenty for aerobic exercise if you're doing it on its own. If you're coupling it with resistance training, then 30 to 40 minutes is plenty, and in our case we use 30 minutes. Resistance training, so twice per week at a minimum, 3 days is ideal. and not on consecutive days. So we want to give your muscles time to rest and repair following exercise, and that usually takes 24 to 48 hours as well. So working at a 50 to 60% 1 rep max range, and that basically is 1 rep max is basically how much weight you can lift for 1 repetition, and that's essentially your strength. And then we work at a 50 to 60% of that to determine how heavy the patient should be lifting, and so on. Duration, exercises, repetitions, and sets: 5 to 10, 10 to 15, and 2 to 4. We basically just do 6 exercises for 10 repetitions and 3 sets. So 3 sets of 10 is the easiest way for people to think. We don't want to try and make things too complicated by saying do this exercise 12 times, do this exercise 10 times. Just make it easy and you'll have better adoption moving forward. What we specifically do for our diabetic patients, we run a program called Diabetics. Basically, following a referral from the GP, they would come in to see us. We would conduct an initial assessment where we do a comprehensive health and musculoskeletal injury screen. We also check vitals and observations as well. So basically, we run blood pressure, heart rate monitoring. We do a single lead ECG screen using this really cool portable single lead ECG screen, and basically what it does is it just
5 minutes.
It just utilizes your mobile phone and the piece of equipment to basically screen for the 4 major arrhythmias, and then we can flag that if we need to and send a copy of the ECG with them back to the GP to get followed up. Following the screen, we identify and stratify the issues and basically use that in the development of their exercise program. We'll also engage in patient education for blood sugar level control, monitoring and timing of glucose and carbohydrate intake if needed, and again that comes down to how high their sugars are or whether they're on insulin or secretagogues. We give a food, water and sleep diary so that we're able to monitor what they're eating, what they're drinking, and then see where we're going wrong if we're not getting the desired results that we need to, and more often than not we find that lying in their food diary. We then take them through a one-on-one introduction appointment where we basically take them through the actual program that they're going to complete within our group program, and then get them familiarised with the specific pieces of equipment and how it all works. Following that, they'll jump into the actual group class, which runs for 60 minutes, and we do that twice a week. It's supervised by an accredited exercise physiologist, and we take a combined approach of aerobic and resistance training. We stagger it in our design so that we have consistently elevated heart rate over the course of the session, and what I mean by that is that they'll usually start with some cardio exercise. They might jump on the treadmill for 10 minutes. Heart rate will slowly start to rise through that time. Then we get them to do a couple of resistance training exercises. It'll slowly start to drop. Then we'll get them onto maybe the bike. It'll come back up. It'll drop with some more exercise. And so we're just able to keep that heart rate elevated over the hour rather than doing a block of 30 minutes of cardio at the start and then a block of resistance training at the end. We find that it helps the patients to get through the program easier, and there's less resistance to adopting an exercise program. Getting your patients involved. So I'm assuming all you guys know about the EPC. It's the most common one, and it is the most common way that we receive referrals for patients with type 2 diabetes. The thing to point out with the referring is that obviously with this there's referrals for physio in there, dietitian, diabetes educator, podiatry. So you may want a patient who needs some foot care to go to podiatry. Or they may have already used their sessions through the year for physio for some injury rehab, and that's where the next referral comes in, and that's the one that we tend to find is not as widely adopted, and maybe that's because there's a little bit of confusion around it, but basically it's a completely separate referral to the CDM referral, the EPC referral. It's only for patients with type 2 diabetes, and it can be used for exercise physiology and dietitian for group services. Okay, now that gives the patient an initial assessment and 8 supervised group classes. So in our case, we obviously do exercise-based group classes. That one requires a GP management plan or a review, but it doesn't require team care arrangements. Unless, of course, you want to couple it with a CDM plan, then in that case you would need to do team care arrangements as well. Billing is the same, so you guys would bill the same as you would for a GPMP, you would for the type 2 diabetes group referral. And just to give you a bit of a look at what it looks like, that's what the referral looks like there. Many of you will have seen it already, but
2 minutes.
It's a really good way to be able to really give that referral off to exercise in a case where patients would have already used their 5 EPC sessions throughout the year. So yeah, look, that's me done, guys. I appreciate the time, and thanks for having me. Cheers. Thank you.
Thanks, Jacob, for a great overview. Any questions? Okay, well, if there's no questions, we might wrap up this session. Thanks, everyone, for your attention. Okay, there's a morning tea now for everyone next door, and if you'd all like to come back here at 11 a.m. for the next session. Thanks.